We're going to briefly cover what's called peritoneal fluid. Peritoneal and ascites fluid is fluid that forms in the belly, and it usually, a lot of times, that comes from liver problems. And then there's also a fluid called pericardial fluid, which is fluid that develops around the heart. I've probably only done 5 or 6 of those in my life because you don't get a lot of those, but that's the third fluid. So pleural fluid, pericardial fluid, and peritoneal fluid. And unfortunately for peritoneal fluid, there is another name for it, and it's called ascites fluid or acidic fluid. So you'll hear me bouncing back and forth between those two names. They're the same type of fluid. They just have 2 different names, and to be honest, I think they're used about the same. Some people call it ascites fluid, and some people call it peritoneal fluid. So if you get lost on this, I went through this yesterday. Pretty much, I'm answering the objectives in the front of the chapter, okay? But I also have highlighted things that are directly on the test. So everything I'm covering today is either going to deal with an objective being answered or information that's about to get a test question correct as we go through this. Okay, top of page 230. It's not necessarily answering an objective, but I do want you to know that first paragraph right there. I'm not going to read it, but I do want you to be able to know the difference between what's called a visceral membrane and a parietal membrane, right? This is where the fluid lies at. If you take my lungs, for example, okay, there is a membrane on the outer layer of my lungs. That's called the visceral membrane. That's the membrane that lines the organ itself. But then there's another membrane that lines the entire cavity around the lungs, okay? And then that's going to be called the parietal membrane. So I want you to think of it like, let's just say that this is my lung, okay? There's a membrane right here on the outer layer of the lung itself. That's called the visceral, okay? But then there's another membrane, and it's not really that far apart, that basically lines the cavity that the lungs stay in, and that's called the parietal membrane. This area right in here, that's where the fluid lays, all right? So that's going to be if you're talking about the lung, that's going to be the pleural fluid. If you're talking about the heart, that would be called the pericardial fluid. It's a very small area. And the book goes at it from, I try to do it like thinking about a blister, okay? If I take my 2 hands and I pretend this is the visceral and this is the parietal, if I do this long enough, okay, even if I do it very soft and gentle, eventually you're going to get a blister, right? Mm-hmm. Okay? But if there's a little bit of fluid, it reduces the friction, and that's what that fluid is important for. I'm not trying to be morbid or anything, but if you ever dissected the cat or a deer or anything like that, you can clearly see those membranes in there. Yep. I mean, you can distinguish them. So that fluid is very important. And in a lot of disease states, sometimes that fluid builds up and there's too much of it. Sometimes it's something that we really got to test for and look at it really, be very, very critical of it, especially if it's an infection, because you got to determine what kind of white cells are in there and all that. But then other times, it's just a byproduct or it's of a secondary condition. Like I've mentioned to you in this class before, people that have congestive heart failure, that fluid builds up all the time, okay? And so really in the lab, we do very little testing on fluid that builds up from congestive heart failure, okay? They pull it off. Essentially, as soon as they pull the fluid off, it starts to build back up again because the heart's not pumping blood effectively. The physicians already know that. He or she is going to say, look, I pulled off a bunch of fluid, I'm sending it to the lab, but you really don't have to do a lot of tests on it. They know what's going on with that fluid. But if you have fluid from an infection, you really got to test for it. So when we go through this today, we're going to distinguish fluids based on whether they're called transudates or exudates. Exudates require a lot of testing because it's either from an infection or it's from a malignancy, all right? Transudates are from a systemic disorder. They're going to be from something like, if the fluid is forming because the person has congestive heart failure, or in the belly, the fluid is forming because they have cirrhosis of the liver, okay? That doesn't go away, so you're going to have that fluid form continuously. So that's a big part of this chapter, whether we're talking about pericardial, parietal, whatever type of fluid we're talking about, the chapter is gonna want you to distinguish transudates from exudates, all right? And so, as we go through that, you're gonna hear that word constantly.
Question. Regarding parietal and visceral, parietal will be superficial, visceral will be deep, correct?
Visceral is lining the body organ itself, the visceral membrane. Okay, it's a membrane that basically is on the outer part of your lung. If you want to look at page 231 in your textbook, this may answer your question. If you look at page 231, okay, although I don't like this picture, look at the box toward the right side. That's the lung itself. Okay, see the square part to the right that's kind of purple in color? That's the lung itself. But do you see it's got a line pointing that says the visceral pleura?
Yes, sir.
That's the visceral membrane that actually is lining the lung itself. Now go just to the left of that, you'll see another line with a space in the middle. That's the pleural, okay? That's the pleural membrane. That little lane in the center is what they're representing where the fluid should lay at.
All that I get. What I just want to know is about, one is deeper than the other one. These two layers, parietal is more superficial, visceral is more deep, closer to the center of the organ.
Yes.
Thank you.
That's true. Okay, you do need to know the function. You need to know the function, why that fluid is there. All I can tell you is where that's located in your reading is at the very first section that we're in. You'll see the word right dead in the middle. It says lubrication. Everybody see that word lubrication in the very top paragraph? Mm-hmm. It says lubrication is necessary to prevent the friction between the two membranes that occurs as a result of movement of the enclosed organs, such as in the expansions and contraction of the lungs. Every time you breathe, you need that fluid, right? Because your lungs expand and contract, expand and contract. So if you didn't have that fluid in there, those membranes would be rubbing together and eventually you would wear a hole out in it. Everybody feel like they're comfortable with that? The formation, this is your first objective. It says serous fluids. Now they're talking about all the fluids, not just one. Serous fluids are formed as an ultrafiltrated plasma. No additional material is contributed by mesothelial cells that line the membrane. Do you remember when we were talking about synovial fluid and I told you that the synovial sites are in the synovial membrane and they contribute the hyaluronic acid to the fluid to make it viscous? Mm-hmm. They're telling you that this fluid is not formed from cells that are in the membrane, all right? The fluid gets there a different way. Okay. The book is going to tell you it has all to do with what's called hydrostatic pressures and oncotic pressures. That has to do with equilibrium between fluids on two different sides of a membrane, and it also has to do with fluids that are produced basically because you lack proteins, okay, for oncotic pressure. Oncotic pressure usually has to do with proteins for capillary permeability, whereas hydrostatic pressure has to do just with the fact that you have two fluids on each side of a membrane, and if one of those fluids becomes larger than the other, they have to reach equilibrium, so the fluids can form that way. Okay, in the right-hand column on page 230, the first full paragraph, says disruption of the mechanisms of serous fluid formation and reabsorption causes an increase in the fluid between the membranes. This increase is termed an effusion. That's a bolded word you have. Primary causes of effusion can be due to hydrostatic pressure. An example of that would be a patient that has congestive heart failure, or it can be due to decreased oncotic pressure, which has to do with people that have very low protein levels. These are people that have edema, all right, that their feet are swelling up. That's fluid. You may not realize it, but whenever you go to draw blood from a patient and you realize, oh, this patient is puffy, you know, it's like you push in on it and it just sinks in and it doesn't really pop back up. That's due to a fluid buildup, okay? And more than likely, those patients are low in protein. That's what causes edema. All right, it does say, it goes on to say increased capillary permeability. These are going to be things like inflammation and infection and lymphatic obstruction or tumors those also cause effusions, and those are the ones that we have to work up in the lab. Those are the ones that are gonna produce exudates, which is the ones that we have to do protein, we have to do all kinds of chemistry tests, we have to culture it, we have to do a manual differential on it, you have to do a cell count on it. So trust me, if you're working in the lab, I'm not saying it's better for the patient, but you're gonna like those big bottles of fluid that come down that say, look, just hold it in micro. And that means the lab's not testing anything on that fluid. They just pulled the fluid off somebody and they're sending it down to the lab, and just in case that physician wants to come back and order some tests on that fluid, we save it for like 2 weeks, okay? We usually take it in a walk-in refrigerator, depending on where you work at, and they'll let you know how long that you need to store that. All right, specimen handling and collection. This is where it talks about the actual procedures itself. You do need to realize, the only one that really is kind of, I guess you gotta think about it, is whenever a physician obtains pleural fluid, it technically is called a thoracentesis. You've got a bolded word there that says thoracentesis, all right? Whenever they collect peritoneal fluid or ascites fluid, that procedure itself is called paracentesis. Now, pericardial fluid, I hope I'm right when I say this, I think that's called pericardiocentesis, all right? So that one's a given. So pleural fluid, you need to know the procedure when you're obtaining that fluid is called a thoracentesis. It will always be a physician that collects that. It won't be an RN, it won't be somebody from the lab, it's always a physician that collects that fluid. Okay, when you read the next paragraph, it's gonna talk to you about an EDTA tube. It's usually what you're gonna use for cell counts and differentials. Then it goes on to talk about a heparinized tube, which usually what is sent to microbiology or cytology. Chemistry test, it says usually are ran on clotted specimens. Then that very last sentence in the right-hand column on page 230 talks about if you ever get a pleural fluid, sometimes physicians want a pH done on that fluid. I know where I worked at, if that was ever the case, we had to send that specimen to respiratory therapy. Respiratory is who did pleural fluid pHs. They had a special machine to do it. Now, I know what you're gonna ask me, but you should be thinking, well, how come you couldn't use a dipstick and use the pH pad for urine? I don't know, but they wouldn't let you do pleural fluids that way. The only people that could do pleural fluids was respiratory therapy. Now, something that your book is not gonna tell you, but I'm gonna tell you, is that I vividly remember when we would get thoracentesis or pleural fluid sent down to the lab. It comes in a huge container. I want you to think of like a 2-liter Coke bottle, okay, except it's glass, it's not plastic. It's got a rubber top on the end of it. And a lot of times they just bring the bottle down to the lab and then they have a downtime order that basically says all the tests they want done on that fluid. So you have to pay attention, even though I've got it memorized because I did so many of them, but sometimes they expect somebody in the lab to turn that bottle over and stick a syringe needle in it and pull out fluid and put it in a purple top, which goes to hematology, a green top tube, which usually goes to micro, and then a clot tube, which would be a red top tube. That's the reason we have you learn all these colors, guys, okay? That clot tube is going to go to chemistry because they have to centrifuge that first. And then whatever is remaining in the bottle, you always either take to micro or histology. There's a lot of work histology does on that fluid. I'm not gonna get into it, but they take that and they end up processing it, making a cell block, cutting it, putting it on a microscope slide and all kinds of stuff, okay? So you very well may be the one that has to not only distribute those tubes, but you gotta make them, okay? Because they're not, it's not like spinal fluid where the physician pulls out the first spinal fluid and puts it in tube number 1, pulls out the second part, tube number 2. They're not as worried about fluid from the lungs and all of that because usually there's a lot of that fluid. I mean, I've seen them pull pleural fluid off people and fill up 2 of those bottles, and they're the size of Coke bottles, okay, the 2-liter ones. So usually there's quite a bit of fluid or else they wouldn't be pulling the fluid off to begin with, right? Does that make sense? Mm-hmm. Now, I have been going in the hospital lately and I've seen these bottles are getting shorter. Are they smaller now, the thoracentesis bottles?
Yeah, they look like, they're like this, and they're green, and they look like they have orange juice in them.
They're like
Drink
that,
that, but,
they're like your Gatorade kind of, or not
Yeah.
much bigger than
Yeah.
that, right?
yeah, but
Okay.
it's got like a little spout on.
Well, when I worked, they were all double that size. And I will tell you, if you ever, because back in histology, we actually had to pour it over and when we would do cytology, if you ever actually take that little plastic stopper and pop it open, there's a lot of pressure built up in there because it'll blow your hair back if you got hair. It'll blow it back, okay? And you don't ever want to drop one of those bottles. I've seen them dropped in the middle of the lab, and they really smell foul sometimes. Yeah.
Wonderful.
Okay, so let's get in deep in this and start talking about transudates and exudates on page 231 in the right-hand column. Now, after I read through some of this, it's a little bit confusing, but there's a table 12 tac 2 at the bottom of this page that clearly tells you the difference in laboratory values, and it distinguishes exudates from transudates, okay? So if you're studying this at home, I would highly suggest you study table 12 tac 2. Okay, it says a general classification of the cause of an effusion can be accomplished by categorizing it as either a transudate or an exudate. And it goes on to explain effusions from a systemic disorder are called transudates. And it even mentions congestive heart failure and nephrotic syndrome, okay? Those would be, think about what nephrotic syndrome is. You're losing an abundance of proteins, right? So those are systemic disorders. So just think of it. If the patient has a systemic disorder, I don't even care if you memorize congestive heart failure, okay, or cirrhosis of the liver or nephrotic syndrome. Any of those three conditions, the fluid is more than likely going to be a transudate. The fluid will be an exudate if it is coming from an infection or if it is coming from a byproduct from a malignancy. Like if somebody has lung cancer, you can bet that's what causes them not to be able to breathe very well a lot of times, is there's a big infection of fluid that builds up around their lungs, okay? Now that's gonna be fluid that we have to test, that we have to do a lot of work on. It does state in that paragraph that transudates do not necessarily have to be tested, okay? Transudates sometimes are just sent to the lab and they don't even want any lab testing on it. It does state toward the end of that paragraph, it says most reliable differentiation is usually obtained by determining the fluid to blood ratios for things like protein and lactate dehydrogenase. Fluid to blood ratios. That means they do the test on the fluid and they also do the test on the blood, okay? Like a cholesterol or a bilirubin, all right? Now, the way when I first read this book, I noticed that all of the signs that went this way, like less than 0.6, okay? If it's less than, all right, this is going to be a transudate. If it's greater than, it's going to be an exudate. And the best way to understand it is don't necessarily memorize the normal ranges, but go look. If there is as much protein in the fluid as there is in the blood, it's probably an exudate, okay? If there is a lot less protein in the fluid than there is the blood, it's probably a transudate. You can do that for protein, you can do it for LDH, you can do it for all of them, all right? But if you're dealing with a fluid that has almost as much of the analyte in the fluid as is in the blood, you're dealing with an exudate, okay? A lot less than is going to be a transudate. So if I have a fluid and I'm like, I wonder if that's a transudate or an exudate. The first way you can tell is by the color. Transudates are usually yellow and clear, okay? Exudates are going to be cloudy, okay? Think about it. If you have an infection, a bunch of white blood cells, it makes the fluid cloudy. But if that fluid is yellow and clear, it's probably a transudate. Now there is one that we're going to have to talk about that's done on peritoneal fluid that is called a serum ascites albumin gradient, okay? Where the little less than or greater than sign is flipped. But you'll understand why it's flipped when I show you how they do the calculation. So when you go through some of these, again, transudates are usually clear, exudates are usually cloudy. Exudates, usually the sign is gonna be greater than, like for example, the fluid to serum protein ratio, if it is cloudy and it's greater than 0.5 to 1, okay, then that's probably gonna be an exudate. That means there is a lot of protein in the fluid. So make sure you review that chart, table 12 package. Okay, under the appearance of pleural fluid on page 232. On page 232, left-hand column, go all the way down to the bottom of the section that says appearance. I'm about 3 lines down into that. It says normal and transudate pleural fluids are clear and pale yellow. Turbidity is usually related to the presence of WBCs and indicates bacterial infection. It can also indicate tuberculosis or an immunologic disorder such as rheumatoid arthritis. Now, another objective. The presence of blood in the pleural fluid can signify a hemothorax, which is basically blood that has entered the fluid due to a traumatic injury, like a crush injury. Or it can be membrane damage such as occurs in malignancy or a traumatic aspiration as seen with other fluids. To differentiate a hemothorax from a hemorrhagic exudate, I want you to think of a hemorrhagic exudate as fluid that is formed because there's a malignancy there or there's an infection there, okay, and it's bloody. It's causing the fluid to be bloody. A hemothorax, just think you're in a car wreck, okay, and you take a major shot to the chest area and blood is spilling into your pleural fluid, okay? That's a hemothorax. So how we can distinguish these two is you do a hematocrit on the fluid, okay? Now I know this sounds crazy, but when they send you the fluid, you do a hematocrit. You spin it down. If there's a lot of blood in that fluid, more than likely it is from a hemothorax. It's from a crush injury because you had a lot of blood just enter the fluid all at one time. But if the blood is just gradually getting into the fluid due to an infection or maybe a malignancy, your hematocrit is going to be really low. So the book is going to tell you, if you do a hematocrit, like if I'm doing a hematocrit on Tanner, let's just say he has a lot of pleural fluid and it's bloody. And I'm wanting to differentiate, is it a hemothorax or a hemorrhagic exudate? What I'm gonna do is I'm gonna take the fluid that they pull off of Tanner's lungs. I'm gonna see that it's bloody, so I'm gonna take a hematocrit tube and spin it down. Now remember, the hematocrit is gonna be low. It's not gonna be as high, but I'm also gonna do a blood hematocrit on Tanner. If Tanner's blood hematocrit, let's say it's 35, okay? If the fluid is more than half of that, like let's say it's 18, all right? Then if it's 18 or higher, we consider it a hemothorax. If it's less than 18, then we consider it, there's blood in the fluid due to an infection or a malignancy. Everybody understand that? All right. So that's how you distinguish those two, and that's an objective that you need to be aware of. Okay, if the fluid is milky in color, I'm in the next paragraph on page 232. It says the appearance of a milky pleural fluid may be due to the presence of what's called chylous material from a thoracic duct leakage or pseudochylous material produced in chronic inflammatory conditions. It says chylous material contains a lot of triglycerides, where pseudochylous material has a higher concentration of cholesterol. So there is a stain that we can use called Sudan 3 that detects triglycerides, right? So that's what you would use to determine the difference between chylous and pseudochylous material. If it has a lot of triglycerides in it, it's chylous material from a thoracic duct leakage, right? If you were to see cholesterol crystals, all right, in the fluid, that would be pseudochylous material that can be from infection. I don't think that I've ever seen cholesterol crystals in pleural fluid, but again, this is just a point that the author is trying to make in this book, that if you happen to have a fluid, I have seen milky pleural fluid, all right? You'll see that a lot where the fluid is milky. but I have never actually looked at that when I'm doing the differential. That's where you're gonna see the cholesterol, crystals, is when you're doing the dip. I've never seen those crystals with the little notched edges from cholesterol crystals. All right, hematology tests. I'm in the last section on page 232 in the right-hand column, drop down to the third line. It says primary cells associated with pleural fluid include macrophages, neutrophils, lymphocytes, eos, mesothelials, plasmas, and malignant cells. Remember, there's a lot of people walking around out there that have a lot of fluid. They may not even know it at the time, but it's a byproduct of possibly lung cancer, okay? So you can see malignant cells in a lot of these fluids. Generally, it's gonna be in pleural fluids. They mentioned a cell called a macrophage. You guys, tell me something about macrophages that you remember from serology.
They eat trash.
Okay, right, they eat trash. They're kind of like the scavengers, right? I just watched a little YouTube video on it to make sure that I remembered what they were. They're like a big, huge cell, okay? And they just basically are floating around in the fluids. Any type of bacteria, organisms, they say they have amoeba-like action. They just take care of any trash that's in the fluid. Seeing a macrophage is perfectly normal to see in a fluid. But when you see them, you're gonna think, oh my gosh, what's that? That's like a cell I've never seen before. If you remember in serology, monocytes that are in the bloodstream, okay, they actually escape the bloodstream and they go into the tissues and they become macrophages, all right? The macrophages used to be a monocyte, all right? So those macrophages are very large, and I just want you to think of them as scavengers, okay? And you will see a lot of those cells when you do your differential. That means you did a cytospin on the fluid, you stained it with a right stain, and you look at it and you go, oh my gosh, what is that? That's not a seg like Mr. Turner talked about. That's not a lymph. I know it's not. But it's totally normal to see macrophages. There's also some cells you can see that it mentions called a mesothelial cell that we're going to talk about. And mesothelial cells, they look bad too. Okay, you're going to think, oh, what's that? And the best way I can describe a mesothelial cell is it has a fried egg appearance. The cytoplasm, when I show you a couple of pictures, if you look, it looks like a fried egg around the edges, okay? Mesothelial cells are also very, very common in pleural fluid. You can see lots of them. What they're worried about in pleural fluid is if you don't see any mesothelial cells, because that can indicate a patient that has tuberculosis, okay? Again, you'll never make that call, okay? But it is nice to know, like, you know what, I did this whole diff and I didn't see one mesothelial cell, all right? And that physician knows, he or she's just sitting up there going, I wonder if this patient could have tuberculosis, you know, because whoever did this differential on this pleural fluid, they didn't report that they saw any mesothelial cells, okay? And I'm banking that you guys know what all the other cells look like. Like, how would we identify an eosinophil?
Segment.
Okay. How would we identify a neutrophil?
The segments.
Okay. Lymphocyte.
Yeah.
Nucleus, usually it's smaller. Remember, when we do a differential on these fluids that we've been talking about, it has usually been through a cytocentrifuge process. They're gonna look a little distorted, okay? You're gonna look at them and go, whoa, what's wrong? That thing has vacuoles in it. It looks like it's distorted, the shape of it. You just kind of got to see your way through that and call it what it most resembles. Yeah.
If we see all that distortion after a cytocentrifuge, we should assume that albumin is not used extensively.
No, it'll look like that with albumin used.
Really?
Yeah. It's if you don't use albumin, it'll even look worse. Okay, so I guess we should I should show you some of these pictures. Look at that picture, 233, top page, top of the right-hand corner on page 233. I don't think I've ever showed you guys a real good one, but if you look at that cell that is in the dead center of that picture, see that big round body and it looks like a seg is around the edges of it? That is a neutrophil that is an actual LE cell. That is what's called lupus erythematosus cell. You guys know LE is where the body is attacking itself, right? It's an autoimmune disorder. Well, in that particular picture, they actually caught a cell in the middle of where you have a seg that is probably eating a lymphocyte. You guys see that cell in the very middle? It's like the one with the big round nucleus, and then right around the edges, you can see the nucleus of a neutrophil that's engulfing. Yeah.
So this engulfing action is phagocytic in nature, but it's not to be confused with a macrophage, correct?
Right. And so do you guys see those cells in there? Do you see what I mean by they're distorted? Okay, the cells, when you guys did your differentials in the summer, they were real pretty. You know what I mean? They were perfect. No, I'm not saying they're perfect because y'all were using old slides, but you can just tell, you can tell a lymph from a mono, from a seg and all of that. But they're going to appear distorted after a cytocentric process. Since we mentioned mesos, turn to page 234 real quick. You guys see figure 12, tac 5. See that cell in the dead center? Again, I'm talking about the fried egg appearance. Do you not agree that the cytoplasm around the edges looks kind of like a fried egg? That's a mesothelial cell. You've got some mesothelial cells in the picture below it too. But then they start talking about a differentiation between mesothelial cells and what they call reactive mesothelial cells, to where they really start looking crazy. Look at that figure 12, tac 7. See those huge cells on the left? They're calling those reactive mesothelial cells. We didn't even have a format to report out reactive. We just reported out mesothelial cells, okay? So some of this stuff, I think, goes a little over the top. They might teach you a little more about it in UT school, but for this class, I just want you to be able to recognize a mesothelial cell as having a fried egg appearance, okay? And they are perfectly normal. Mesothelial cells are found in the membrane that lines the lungs, okay? And so it's perfectly normal to see macrophages, and it's perfectly normal to see mesothelial cells. What you don't want to see is, if you'll look at figure 12, tac 8, you see those two round cells that have a nucleus that's eccentric all the way over to the edge? You guys remember what those are? Plasma cells. Remember? Now, the way Jason and I taught it to you is a plasma cell in the blood. If you'll remember, that's an indication, if you see it in the blood, of multiple myeloma. Okay? But remember, we always told you there would kind of be a central area of power just on the edge of the nucleus where it goes into the cytoplasm. You can kind of see that in these cells, right? But when you see plasma cells in pleural fluid, you need to be thinking tuberculosis, not multiple myeloma, TB, all right? Plasma cells in pleural fluid is an indication of tuberculosis. Okay, so there's a good table you can study on page 233, table 12, tac 5. It basically tells you the significance of cells seen in pleural fluid. I do want you to add a couple of things to this chart that they left out that I think is pretty important. The very first cell, you see where it says neutrophils can indicate pancreatitis? Right above that, I want you to write down bacterial infections. Bacterial infections as well. I don't know why they left it out. And it's even in your reading, but they left it off of this chart. And they also left off, what about eosinophils seen in pleural fluid? And so also add at the bottom of that chart eosinophils. And those can be seen in trauma, allergic reactions, and parasitic infections. Trauma, allergic reactions, and parasitic infections. Okay, is everybody good so far?
Yep. Question.
Yep.
On those neutrophils, you said infection.
Okay, page 233, right-hand column, first sentence. I've already told you this, but I want you to at least have it marked down in your book. It says, the membranes lining the serous cavities contain a single layer of mesothelial cells. So it is not unusual to find these cells in serous fluids, but generally they're going to be in pleural fluids. Okay, skip down about probably 10 lines right there beside where it says figure 12 tac 6 and 12 tac 7 in parentheses. It says an increase in mesothelial cells is not a diagnostically significant finding. It does say that they can be increased in pneumonia malignancy, but this is where it says of more significance is the noticeable lack of mesothelial cells associated with tuberculosis. This is because the exudate is forming, or it's actually blocking the pleural membranes to where the mesothelial cells can't get in the fluid. When you think of TB, you need to think of like your lungs have this real thicky coat around them, and it won't allow those mesothelial cells to be in the fluid. So I told you what the mesothelial cells look like, and I told you the macrophages. You know, I'm not gonna lie to you, when I used to do dips on pleural fluid, what I would do is, I knew all the white cells, like I knew what a seg, EO, and all of that stuff looked like. And I knew the mesothelial cells usually had a fried egg appearance. Any cell I saw that didn't look like that, I called it a macrophage. But see, I really didn't know what macrophages looked like. See what I mean? But it was just like, any crazy cell that was super big, that had vacuoles on it, as long as it wasn't molded to other cells, and we're fixing to talk about that, what the significance of that is, I usually call it a macrophage. Okay, that's how I call it macrophages. Yep.
You've seen vacuoles in monocytes, correct?
Yep.
Okay.
Sure will. Okay, but you do need to at least be able, as a tech working in the lab, when you're looking at a pleural fluid, you need to at least be able to recognize carcinogenic cells, okay, from metastatic diseases and things like that. So let's read about that. Page 234, first sentence. It says, distinguishing characteristics of malignant cells may include nuclear and cytoplasmic irregularities, hyperchromatic nucleoli, cellular clumps with cytoplasmic molding. I think that is the most important thing to identify. Remember that, cytoplasmic molding or community borders. It basically means you see a bunch of cells that basically look like all the cytoplasm are just molded to one another, okay? It says malignant pleural effusions most frequently contain large, irregular adenocarcinoma cells, and then it goes on to talk about small or old cells and metastatic cells. I don't think that you will ever be asked to call what a malignant cell is, but you need to at least be able, if you're looking at a pleural fluid and you see cells that obviously are not mesothelial cells or macrophages or any of the normal white blood cells, you need to be able to refer it to pathology. Okay, so let's look at some of these cancer cells. I think the best picture of a malignant cell is figure 12 tac 9. It says pleural fluid adenocarcinoma showing cytoplasmic molding. Do you see how you can tell that's like 5 different cells in that picture, but do you agree that the cytoplasm just seems to be molded in all of the cells together? Okay. That is a major indication that you're looking at a malignant cell. And I've got some pictures that I'll show you guys when I get finished lecturing of CAP surveys that were sent to our lab where we're supposed to call them malignant cells.
So this molding you're talking about, it's another way of saying they're clumped together.
It clumps together, but the clumping together is usually the cytoplasm of every cell, just sticking to one another.
Yeah, okay.
And that doesn't mean in every case they're gonna look like that. A lot of times you can still look for the very center of the nucleus and you'll see big nucleoli in a lot of your malignant cells as well. You just need to be able to remember to refer it to pathology.
Those nucleoli, they'll be darker in color than you should expect?
I don't know that they'll be darker. Sometimes they will be, but not in every case.
But definitely visible though.
Yep. Usually, I mean, again, it depends on the malignant cell, because we're not pathologists, you're not expected to call that, but you just need to be able to refer it. Now, I'm gonna tell you about a kind of a protection that you have in the lab on this. In my encounters, any body fluid that is sent down to the lab, most of the time they have a cytology order on it. When it has a cytology order on it, you really don't have anything to worry about, because that basically is saying, I want a pathologist looking at the cells in this fluid. So back in histology, which you're not gonna see what's going on back there, but they actually are spinning this fluid down, and they're making slides of this fluid too, and there's gonna be a pathologist look at all the cells from the same patient that you're doing the differential on. The way you can kind of get in trouble, and I mean, you're not in trouble, but I have seen pathologists call somebody out, and they'll go, hey, Britt, you did a differential on John Doe over here on this pleural fluid, right? And you reported out 77 macrophages, 19 mesothelial cells, 5 segs, and 4 limbs, or whatever adds up to 100. And then they'll go, did you not see all those malignant cells in there? You know what I mean? And because, see, they've already did the diff on it. So you're not in trouble, but sometimes they'll just say, I've had pathologists, seen them call techs in their office and like say, hey, look at this. I want you to remember what this cell looks like, is this is a malignant cell that's in that fluid that you did the differential on, okay? The patient still doesn't go untreated. I mean, you said, it's called, the pathologist has seen these and has reported them out, but it's usually a tech that does the differential. Now, we had, where I worked at, I think I've told you guys this, my supervisor, her name was Polly. We had a little spot in hematology that was called Polly's Corner, okay? So if you ever did a diff on anything you felt uncomfortable with, you just put it in Polly's Corner. And she was the hematology supervisor. And at the end of the day, if she had 3 body fluid diffs that I didn't feel comfortable doing, you know what I mean? Like I saw cells that I wasn't sure about, she did them all, okay? So don't be afraid if you're a tech working in a department, don't be afraid to say, I'm not comfortable doing this differential. I'm seeing cells that I'm not sure what is. I don't want to call them just to get it done, okay? There's usually a supervisor that wants you to defer that to them, all right? That especially things like bone marrow differentials, body fluids, things like that. Usually there's somebody that you can at least get a second opinion on. And by the time you guys start working with technology the way it is, I know they already do it at some places. You can be looking at in a microscope at a cell that you're unsure what is, and you can take a picture of it and email it to the pathologist, and then they'll email you back what the name of the cell is. Now, I never was doing that, but that's newer technology. Okay, let's talk about pericardial fluid. We talked a lot about the lung fluid. There is a great chart on page 236 that is in a logarithm that you can determine how pleural fluid is actually tested. That probably would help you answer a couple of questions on the exam. But let's move over. This is going to be a short one, pericardial fluid. This is fluid that's found around the heart. You won't see these very often. There generally is not going to be as much fluid. Usually, I think in the book it says 10 to 50 mils of fluid is usually all there is if it's pericardial fluid. It says pericardial effusions are primarily the result of changes in the membrane permeability due to infections such as pericarditis, malignancies, trauma-producing agents, and certain metabolic disorders such as uremia, hypothyroidism, and autoimmune disorders are the primary causes of the transudates. Now that is the answer to an objective in the front of the chapter, okay? It basically tells you which disorders will cause pericardial fluid buildup, okay? So that answers that. As far as the appearance, over on page 237, says normal and transudate pericardial fluid appears clear and pale yellow. For the most part, that's going to hold true for all fluids. Yellow and clear is usually considered a good thing. Usually if your fluid is yellow and clear, you're not going to see an abundance of white cells, or you're not going to have markedly increased levels of protein and all of that. Usually that indicates kind of like a normal fluid. All right, so now we're going to move to peritoneal fluid. Peritoneal fluid, if you want to in your book, you might write in parentheses beside that, ascites fluid. I'm in the right-hand column on page 237, it says accumulation of fluid between the peritoneal membrane is known as ascites. The fluid is commonly referred to as acidic fluid, rather than peritoneal fluid. I've heard it called both. In addition to the causes of transudate effusions discussed previously, liver disorders such as cirrhosis are frequent causes of ascites transudates. Again, cirrhosis of the liver will cause there to be fluid in the belly or the abdomen area, and that is going to be a transudate. Then he goes on to say bacterial infections such as peritonitis, often as a result of intestinal perforation or a ruptured appendix. That happens a lot. And malignancies are the most frequent causes of the exudated fluids. So again, it holds true to what we began this lecture about, okay? Transudates are usually just a byproduct of a systemic disorder. Exudates are coming from something that is due to infection or malignancies around that area of the body. Okay, peritoneal lavage. I'm in the second paragraph under peritoneal fluid. It says normal saline is sometimes introduced in the peritoneal cavity as a lavage to detect abdominal injuries that have not yet resulted in fluid accumulation. Peritoneal lavage is a sensitive test to detect intra-abdominal bleeding in blunt trauma cases and results in a red blood cell count. It can be used along with x-ray procedures to aid in determining the need for surgery. Anytime you have a red blood cell count greater than 100,000 per milliliter, this can be indicative of blunt trauma injuries. Okay? So how I make sense of that, you have a person that's been in a car wreck. They come in through the ER. And the physician is saying, we have got to do a CT on this person, or we've got to do this particular test in order to determine if there's abdominal bleeding, okay? So the way I think of it is they have a big old syringe full of saline, and they stick it into the peritoneal cavity, and they shoot all that saline in there, okay? And then they're gonna wish it around, think about getting the patient rolling over and doing whatever. In other words, you're sloshing it, okay? You're sloshing that saline that you just introduced to see if there's any type of blood in that cavity. Now they're gonna take another syringe and they're gonna pull that saline back out. Make sense? Mm-hmm. If there's blood in that saline, that means there's bleeding going on in the abdomen. Okay. All right? Now, that is an archaic way of doing things, okay?
Yeah.
And I understand that, but that's what they mean when they're talking about this. You're basically introducing saline into a cavity, and then you're taking the same saline back out to see if there's red blood cells in it. And that's known as a peritoneal lavage. The only thing they're worried about in that test is how many red blood cells are in that fluid, okay? Because, think about it. If you wait until the belly starts expanding, well, that's doing damage, right? You want to detect abdominal bleeding as quickly as possible. Now, that's not to say that there's not sophisticated x-rays that can determine that a lot easier than a peritoneal lavage. But you do need to know what that word is, because I think there's a question on the test about peritoneal lavage. Okay, transudates versus exudates when we're dealing with peritoneal or ascites fluid. It says differentiation between acidic fluid transudates and exudates is more difficult than for pleural or pericardial effusion. There's a test called a serum ascites albumin gradient recommended over the fluid to serum protein or lactic dehydrogenase ratios to determine transudates of hepatic origin. It says fluid and serum albumin levels are measured at the same time or concurrently, and the fluid albumin level is then subtracted from the serum albumin level. A difference of 1.1 or greater suggests a transudate effusion of hepatic origin, and lower gradients are associated with exudated effusions. So they give you an example on page 238. Go turn to page 238. They got an example underneath that blue box. It says if the serum albumin is 3.8 and the fluid albumin is 1.2, you agree, you just subtract the two numbers, right? You take the serum albumin minus the fluid albumin. In this case, it comes to 2.6, so this would indicate a transudated effusion. Do you You guys agree? Because of the 1.1, a difference of 1.1 or greater suggests transudated origin. But in the next example, they give you a serum albumin of 3.8 and a fluid albumin of 3. That gives you a gradient of only 0.8, which means it's an exudative effusion. Okay, just one minute there. But the thing on this is, guys, if you'll go back to what I told you earlier, think about it. In exudate, if the serum albumin is 3.8 and the fluid albumin is 3, that means there's almost as much albumin in the fluid as there is in the blood, right? Which means it's an exudate. Remember what I told you? I don't care what they're testing for. If it's things like protein, LDH, cholesterol, anything like that, if there's a lot of that in the fluid, I'm not saying it'll be as much in the blood, but if there's a lot of it in the fluid, that's an exudate, all right? Transudates are not going to have as much of those analytes in the fluid, all right? Yeah, I'm sorry, Darren, what you have?
Okay, in your example, when you're talking about these gradients, I see the word gradient and I'm thinking difference.
Difference.
Is that right? Okay, thanks.
Okay, there's a couple more carcinoma cells at the top of page 239. You guys see the cytoplasmic molding in those pictures, figure 12 tac 19 and figure 12 tac 22. You guys see how those cells are the nuclear molding or the cytoplasmic molding?
Yeah.
Okay, on page, let's see where we're at. Page 239, under chemical testing, it says chemical examination of acidic fluid consists primarily of a glucose, amylase, and alkaline phosphatase determinations. It does say in the next column, if you'll go to the first full paragraph, it says sometimes you can measure the BUN and creatinine in an acidic fluid or a peritoneal fluid if it's requested because the physician may think that they may have possibly ruptured the bladder when they were going in to remove the peritoneal fluid. Think about where the belly's located, right? Okay, now even though they have needle-guided ultrasounds and all that stuff now where they don't mess that up, but basically, if you are ever obtaining fluid from any area that's close to the bladder, you have to make sure that you don't puncture the bladder, right? Because that can't happen. So if you got urine in that fluid, do you guys agree? Remember, there's a lot of BUN and creatinine in urine. So if you had an elevated level, that could give the physician an indication that they may have ruptured the bladder or stuck the bladder when they were going in to try to get that fluid in. Make sense?
Mm-hmm.
On page 240, serologic test. This is another objective, or I probably wouldn't have put it in there because I think it has more to do with chemistry. It says you can do a measurement of certain tumor markers on fluids. For example, a peritoneal fluid, it says measurement of the tumor marker CEA, which we haven't covered this chapter yet in chemistry, but we will. That stands for carcinogenic embryonic antigen, and the cancer antigen 125 are valuable procedures for identifying the primary source of tumors producing acidic exudates. The presence of a CA125 antigen with a negative CEA suggests the source is from the ovaries, the fallopian tubes, or endometrium. Basically what they're saying is sometimes there will be peritoneal fluid in females, and that fluid is being produced as a byproduct of a woman that has ovarian cancer. One of the tests they can do to show that is a CA125. They can also do that test off of serum or plasma, and that is a cancer marker for ovarian cancer.
I had a CEO from my job, his wife died, I think it was past year's mother. She fought it and then it came back and why did you take it?
Yeah, it's a bad deal. Cervical cancer, ovarian cancer, but not gonna get that. All right, let's see if we can answer some of these questions. I've got a lot of them answered. Then we'll take a break.
How to get up and walk
Number
around.
one, the primary purpose of serous fluid is to
Lubricate.
C, lubricate serous membranes.
Yep.
Number 2, the membrane that lines the wall of a cavity is what?
Visceral.
It lines the wall of the cavity.
Not the wall.
The parietal membrane.
Yes.
Remember, the visceral membrane lines the organ itself.
Yeah.
Okay? And in between those two membranes is where this fluid is. Does everybody understand that? If you leave here today, if you don't remember nothing I said, I want you to remember that, okay? There's two membranes, all right? The fluid we're talking about in all of this lecture is the fluid that is in between the two membranes, okay? And usually there's not very much of it. Number 5, an increase in the amount of serous fluid is called what? An effusion. C, effusion. Number 6, pleural fluid is collected by what? What's the
Paracentesis?
Paracentesis. Now, number 7 is a really good question because this is where it's basically telling you the condition and you have to predict whether the fluid is a transudate or an exudate. Okay? So, the very first one, caused by increased hydrostatic pressure. Remember how we talked about congestive heart failure is known to do this?
Transudate.
That'd be a transudate. Caused by increased capillary permeability.
Transudate.
I think that's gonna be an exudate. Let me look that one up, but I think that's an exudate. The next one, caused by decreased oncotic pressure. We know that one for sure. Transudate, nephrotic syndrome, right? Anytime you're losing proteins, that has to do with oncotic pressure. Caused by congestive heart failure. Transudate. What about malignancy? Exudate. Tuberculosis. Good. Endocarditis. Exudate. Anything that is inflammation or infection is an exudate. And then clear appearance. Transudate. Remember, transudates are always going to usually be yellow and clear. Now, you're probably thinking the same thing I thought. Well, if you know it from the color of it, Ryan, you got to worry about all this other stuff, right?
All things
you know it
like-
from just it's yellow and clear, but that's the way it is. Number 9, which of the following requires the most additional testing? You got a 50-50 chance.
B, exudate.
Good, exudate. Remember, transudates are the ones sometimes that they don't even want us testing. Number 11, I don't expect you to get this one, but maybe you'll get part of it. A milky appearing pleural fluid indicates what?
D.
Good, D. It can indicate a thoracic duct leakage or chronic inflammation. Remember, that's where you have to check for the Sudan 3 stain or the cholesterol crystals. I didn't go over this with you, but I think that you should be able to get it right. Number 13, and there's a good picture of these cells in your book. I just, for whatever reason, I skipped over it. All of the following are normal cells seen in pleural fluid except
D?
D. You don't want to see mesothelioma cells. That's bad.
Well,
You
the
can sue
oma.
them over that.
I was gonna say, doesn't the oma part indicate like cancerous anyway with everything?
And there is a good picture of 2 mesothelioma cells. You guys know what those come from? Or what they
Asbestos.
Good,
Yeah.
asbestos.
There's all kinds of lawyers.
Number 17, plasma cells seen in pleural fluid indicate what? Tuberculosis, good. This is a good one too. Number 18, a significant cell found in pericardial or pleural fluid that should be referred to cytology or pathology would be which of the following? The one I didn't talk about. B, mesothelioma cell. 19, another name for peritoneal effusion is ascites. Number 20, a test performed primarily on a peritoneal lavage fluid would be which of the following?
Yeah, the
Blood
B.
cell count. Let's do number 22. Given the following results, classify this peritoneal fluid. The serum albumin is 2.2. They threw in the serum protein to throw you off. And then the fluid albumin is 1.6. So would that be a transudate or an exudate?
Transudate?
Transudate.
It's gonna be greater than
It's 1.4.
0.6, so
Wait, 0.6.
2.2 minus 1.6 is
Oh.
what it is.
or is
Yeah.
it less than 0.6? I don't have calculator.
It would be an exudate.
Okay. Whoops.
Number 24, detecting the CA-125 tumor marker in peritoneal fluid indicates
Ovarian cancer.
ovarian cancer. On these case studies for this chapter, I would definitely be able to do number 1 and number 3.
Thank you.
So that leaves us, and I know it's time for break, that leaves us with 2 chapters left in this book. We will not cover chapter 15. The next chapter is gonna be over amniotic fluid, and then the one over that is gonna be over fecal analysis, and then we will be finished. So we have 2 weeks left of lectures, and, of course, I don't have a lab for amniotic fluid. I may show you guys some pictures and stuff here in that lab. There is a lab for fecal analysis, because I at least want to show you guys how to make and do the test and interpret the test for what's called a fecal occult blood. They are really, really simple to do, but you need to leave this program knowing how to do them. Okay? 'Cause they take
What
a long time.
is
There's a
this?
few pictures I want to show you guys back here, some of the stuff we
Okay.
talked about today. I don't have very many.
Came out of nowhere and I was like, what's going
We
on?
want to break it.
Yeah, yeah. Oh wait, we're gonna go back to the back.